because all this medication will stop them from ovulating, stop them from having a baby. So that is another consideration. Now, of course, have cancer before. Can I get pregnant? If I get pregnant, will I have recurrence of the disease? Would it, jeopardize my survival rate? So I think there's a lot of psychological impact as well in terms of, breast cancer survival getting pregnant. And you quite rightly pointed out that a lot of women delay childbearing because of career, because of social circumstances and so forth. And therefore, when they come to see us, the fertility doctor, because that would also be the same age band as well. So they are actually struggling with fertility. And also breast cancer.
Correct,
I think that is actually very, very, sad for them.
Okay, so breast cancer treatment, I mean, the type of medication they're on that stops the hormone does affect future pregnancies if they are still on the medication.
What happens is, if they are on the treatment with anti-hormonal therapy, we not allow them to get pregnant because the hormones may affect the fetus, the baby that they may conceive. So if they want to have a child, if they have already discussed their risk with their oncologist, we usually will stop the hormone for a while and then allow them a few months of period before they try to conceive. And then if they are able to conceive, then they go throughout the pregnancy, in a few more months a bit for the breastfeeding maybe, before they resume.
I see.
So that's a lot to take for a woman because they have to say, okay, if I stop the pills, would my cancer recur? I mean, you're not sure yet whether you're going to get pregnant or not.
Absolutely.
You're not sure yet. You're trying unless you're doing implantation. But there's a lot of things that have to be discussed or have to be considered.
Okay, that's good to know, and also for all the female breast cancer patients or survivors out there. So, Dr. Masura, why are, I guess, pregnant patients being diagnosed at later stages?
Back to what happened to the breast, the physiology of pregnancy to the breast. So when you are pregnant, the breast gets more engorged, right? And then it gets basically bigger. So when the breast is bigger, and people also say, oh, if let's say you have something in the breast and people say, oh, it's blocked ducts, it's blocked milk ducts, okay? And then if you have a lymph node in the armpit and they say, oh, of course you're pregnant, you're gonna get lymph nodes in the breast. It gets later, at later stages at diagnosis because of the changes in the breast, making it more difficult to fill for the lung. And second is the stigma. That the stigma of the blocked milk ducts. So I often get patients going to see a doctor in a general practitioner, a GP clinic, and they will brush it as a blocked duct or normal cancer pregnancy changes in the breast. Maybe Dr. Halina can.
Absolutely. And then a lot of times when you ask them to do an X-ray, a mammogram, no, because it will actually harm my fetus.
That's
Whereas they didn't realize that the X-ray that they are exposed to is actually very minimal compared to if they actually go on a flight to London, for example. So I think there's a lot of myth going on, a lot of misunderstanding, a lot of, I think, people are not well informed that there are things that we can do and which is quite safe in pregnancy. So I think a lot of concern to the fetus in order to
we do under in your body, right? But X-ray, ultrasound of the breast is something that it can easily be done, and is like zero. You don't, right? You can do a double shield to the abdomen so that you can protect the fetus from getting the radiation. So these are things that have been people have feared, but it's very, very standard of care.
So we need to break the misconception about how to detect breast cancer, especially in pregnant women.
Yes, women who are pregnant can get breast cancer. Women who are pregnant can be evaluated just like any women without breast cancer. There are safe investigations or safe procedures that can be done on women who are pregnant with breast cancer, similarly like women without pregnancy with breast cancer.
It's a standard of care, so we hope that all are tuning into this and listening to that. So Dr. Helena, what should be done prior to starting cancer treatment?
Okay, well, the thing is, when you are actually faced with cancer, it's so life-threatening in the sense that your world fall apart completely. And a lot of times, people are actually they are it's absolutely right, they focus on survival. But I think a lot of treatment, for example, chemotherapy, for example, or radiotherapy, but can potentially affect your fertility. I think especially so in breast cancer, we're talking about chemotherapy.
Yeah.
So a lot of times, I think a lot of times people are not aware that you can actually think of ways and means to preserve your fertility before the cancer treatment. For example, egg freezing. For example, embryo freezing, if you're actually already in a marital relationship. So I think that has to be discussed, and that information and message had to be disseminated, throughout, quite rightly with the proper channel.
Yeah.
So I think that's something that we are now interested to actually get the message across.
Yeah. It's very, very right. So any women who are diagnosed with breast cancer, they're not pregnant yet, but they would like to get pregnant later, but they need to treat the breast cancer now. So the older their age, not just that their fertility is already declining, right? Then the likelihood of them getting infertility from cancer treatment is higher. The higher your age, and when you receive the treatment, the higher your risk. So it's not like you have to be treated now, right now. It's not like that anymore. You can have time, and I believe that now your ovarian stimulation, right? And then the oocyte preservation, the embryo preservation does not take like a month like last time.
Not
It
anymore.
can be done like in 7 days, in 10 days for my patients.
Yes,
So I can just refer my patient over, they have it done, and in 10 days I can start the treatment already. So it's no longer like last time. Am I right?
Yeah, absolutely.
Yeah, so
Because the fertility stimulations now typically is about 10 to 12 days. And there are now many ways also.
Yeah.
And some of the drugs that we use can also, that you use as well,
reduce
is actually reduce
the-
the chance of cancer recurrence. For example, tamoxifen.
Yeah,
And we do tamoxifen as well, because we use that to stimulate eggs to grow as well. So there is actually a lot of new things, and then there's a lot of conversation that we should be talking about.
Right, yeah. In fact, when we let's say we're giving the chemotherapy, we can also give the GnRH, the medicine to suppress the ovarian function, and that helps.
Yes, absolutely.
With the ovarian function. So if sometimes my patient will say, "Oh, doctor, I don't have a partner yet," but you may, you may after this. So you must discuss, although the person doesn't have a partner. Or the person may say, hey, I do not want children, but I do worry about being menopause early. I do worry about menopausal side effects from cancer treatment. And yes, we discuss all this, like GnRH and a lot usage other than fertility preservation, also ovarian function preservation.
And there is a window of opportunity between the cancer surgery and the initiation of chemo or immunotherapy.
So a lot of our younger patients now, we give chemotherapy first rather than surgery up front, because young patients are associated with the cancers like triple negative breast cancer or HER2 positive breast cancer, where even the tumors are small, like 2 centimeter, we already give neoadjuvant chemo before the surgery. So there is time for the patient to think about what they want to do. So that's why that this discussion about fertility sparing efforts should take place.
Thanks, Dr. Masura. Talking about that, you earlier mentioned how breast cancer is diagnosed during pregnancy, which is the standard of care, and a lot of people are their misconception on it does not allow them to do it, right? So in terms of once they've been diagnosed, what is the best time to start the treatment during pregnancy?
Okay, so the treatment for breast cancer can be surgery, this is during pregnancy, can be surgery, can be chemotherapy. We don't give hormones during pregnancy, and we also do not do radiotherapy during pregnancy, so I can actually just discuss this too, right? So the decision about what comes first depends on, of course, the patient's disease, like stage, what type of cancer, and the second will be at what stage is the pregnancy, so at which trimester is the pregnancy. So if, let's say, the patient has an early stage breast cancer and would like to conserve the breast, of course the breast is smaller, but it can, it is still, can still conserve the breast. but the patient is in the first trimester of the the pregnancy. So we are not able to do a breast conserving surgery at that time because we have to give radiotherapy, and there's still 2 trimesters away
I know.
before we can give radiotherapy. So instead of doing a mastectomy, then we say, okay, why do we give you the chemotherapy first? From when you reach your second trimester, we give the chemotherapy, and we stop at 34 weeks, 35 weeks, and allow about 3 to 4 weeks before they reach term, because we want the baby to go to term, so that the baby doesn't have any problem whatsoever. So that's how we modulate things. If, let's say, the patient comes with a more locally advanced cancer, means that the tumor is a bit bigger and then there's lymph nodes, then we prefer to give the chemotherapy first. So we will give the chemotherapy at about a second trimester, about 14 weeks like that, pregnancy, and again we stop at 34, and then the patient can go for surgery. And then once the surgery has happened, the patient can go for delivery. So once the delivery has happened, then after that, if the patient has completed the chemo, then they go and have the surgery, and then we can deliver the radiotherapy and hormones or targeted therapy later. Okay, so if a patient has triple negative breast cancer and they are going to have chemotherapy during pregnancy, we cannot give the immunotherapy, unfortunately, because we can't give immunotherapy during pregnancy, so they're just going to have the chemo. Same thing like if they are HER2 positive, we cannot give the anti-HER2 during the pregnancy, we can only give it after that. So it depends on a lot of things, a lot of especially the gestational age. But we do not give chemotherapy during the first trimester, because that's when the baby's forming.
Organogenesis, they are forming their organs are forming. So
so we don't give, and we also do not give beyond 34 weeks, because we do not want the patient to go into labor and at the same time they're having neutropenia, and there is risk for bleeding because they just had chemotherapy. So we just stop at about 34 weeks. So I think the beautiful time for a baby to be delivered is about 39.
37, everything after 37 will be good.
I mean nowadays they say anything after 37 and above, right?
Because last time they used to induce labor, which has not been done the last 12 years, 12 years. We do not want. There's no need to induce the baby.
So actually, it's not easy to manage a woman who have breast cancer in pregnancy.
Actually, to be honest, the chemotherapy is easier. The side effect is less.
Is that right?
Yeah, the side effect is less. Like nausea, vomiting is less. Not sure. Maybe the physiology of pregnancy, where you get a lot of blood supply, then the elimination distribution is better. But it is actually okay.
Wow. Okay.
I learned something new
today.
It's actually written in the literature, that there are side effects profiles better.
So talking about treatment. So for patients who have undergone cancer treatment, how long should they wait before attempting to conceive, Dr. Helena?
Well, the thing is, it depends also on their tumor stage, whether they need chemo, radiotherapy, or long-term hormonal therapy, for example, tamoxifen and so forth. So usually we would like them to have a conversation with their oncologist as to whether they are allowed to have a pregnancy or not. So I think usually they will come back and say that Dr. Mastura said it's safe. Now Dr. Mastura give me the green light to have a baby. Then the whole process of conversation will start about how we're going to do it, how we're going to aim it, and so forth.
Okay.
I think for us the duration is usually about 2 to 3 years, because we want to monitor the cancer, because the cancer recurrence highest is at the first 2 to 3 years, and then the patient is on hormone. We want them to benefit as much as they can from the hormonal treatment. Then once that's settled, there's no recurrence, because you don't want to complicate it if they have recurrence, right? Then yes, we say, okay, please stay for the to start the ball rolling. Anyway, but what I also want to highlight here is that for women who have hormone receptor positive, HER2 negative breast cancer, so there is that group, and if they have earlier stage disease, stage 1 to 2A, and then they have had the treatment, they are on hormonal treatment. So there has been a study conducted in them where they've divided the patient into a group that ceased their hormonal treatment and tried pregnancy, and those that didn't. And they find that the survival for these two groups of women is the same. So they have followed the two groups of women over 5 years, and they have published their results. They say that the cessation of hormonal treatment in order for them to be allowed to have a child does not impact on their cancer outcome. Of course, it's just 5 years, and we need longer follow-up. But at least it's something
No, but it's
positive. So the study is called positive.
Okay, yeah,
It's
very
called positive.
positive.
Yeah, it is. And the study is called positive. So nice.
Oh, it's very nice.
good.
It's a good news actually.
Yeah,
actually
it is.
for
It
all
is
of
because for many years we don't have any data
Yeah.
to tell our patients. Just go by
Yeah.
our little experience. When patients say, when can I stop, right?
Yeah.
But this is now there's
At least a
actually
study,
evidence.
right? Yeah.
There's evidence.
So, when it comes to the treatment options available, you mentioned chemotherapy and surgery. Are those the only treatment options
pregnancy.
available?
During pregnancy. So
Okay.
from the onset of the cancer diagnosis, the patient can go for a biopsy. The patient can go ultrasound, can have the mammogram. They may even have an MRI, just for staging if the need arises. Then following that, they can have either surgery or chemo followed by surgery, surgery followed by chemo, as long as it's within the window of second trimester to 34 weeks.
34 weeks. Okay. So when it comes to Dr. Helena, I want to know, I think this is a question that a lot of people who have had breast cancer or hormone-related cancers would ask. Can fertility treatments increase the risk of cancer recurrence?
Yeah, I think it's a very good question
an
because
old age and very important question.
absolutely, because I think a lot of people are so fearful that if I have injections, would I increase the risk of recurrence?
That's right.
But study have clearly shown that it has no relationship at all. And even if you need a fertility, treatment after breast cancer, there's no increased risk of recurrence in this kind of patient. So this data has been very clear. Now, even before having cancer, I think a lot of people who come to see us to seek for fertility treatment, they also ask us these pertinent questions. A lot of them are worried that if I have an IVF or egg freezing procedure, would that increase my risk of having breast cancer? And again, the answer is no. Yeah, so I think that's the myth that we need to bust today. Yeah.
I think that is the myth you need to bust because a lot of people have also asked me before, like, I had ovarian cancer or some who have had breast cancer. How do you get pregnant? They would ask me, and I'm like, maybe you should join today's session. No, but after the last session, a lot of people actually asked me, and I'm like, it's best to speak to your oncologist and also fertility specialists because they will be more equipped to answer your questions. So it's funny how a lot of people are afraid to see the specialist when it comes to these tough, important questions. But they rather struggle with it themselves. So talking about struggling, I think, Dr. Helena, I'll go back to you. What do you think are the psychological aspects of fertility concerns for breast cancer patients, and how would you address them?
I think one of the biggest issue is number one, as I said, they are so afraid that IVF or any fertility treatment increases the chance of recurrence. So in fact, sometimes I also tell them that in fact the drugs that we use for stimulation is actually
The drugs
drugs
that we use to treat cancer.
So in fact, some of my patients who go home, and Google search the medication that I use, and they panic and they come and see me, Doctor, are you sure you're giving me the right drug? Because this shows as cancer drugs. I'm not a cancer patient. Are you out of my mind? I think they are all thinking like that. But actually, we have a lot of drugs that we use have similar two actions, two different types of actions. So that's one. Now another issue that I always feel about a lot of patients is that if they carry a gene.
The
BRCA1,
hereditary gene.
BRCA2 gene, for example, and they're so afraid that they will pass it down to their child and all that. Again, it's a very contentious issue because, of course, nowadays you can also do genetic screening. You can actually screen your embryos. Whether to see whether they carry this kind of gene or not.
Choose the embryo that doesn't carry the gene.
Correct.
And implant it.
But again, we all wonder whether we are playing God. We know that
Sometimes we may have to.
yes, because with this kind of
Yeah.
patients, their
Yeah,
chance of
yeah.
getting breast cancer and multiple questions up to 50 to 70%.
Yeah.
So sometimes you just wonder. So of course there are technology to help us to identify whether your offspring will have this disease
Yeah.
or not. Yeah.
So basically, it's like you harvest the eggs of a woman who is a carrier
correct.
of the BRCA1 or BRCA2 gene, or maybe PALB2 gene, which increases the risk of getting cancer of the ovary or breast. So this woman now desires to have a child. So the risk of passing the gene to the child is about 50%.
Yeah.
So you
That's
take
very
out
high.
the eggs, okay, and then you do the genetic hereditary testing on the eggs and find out which one doesn't carry the gene, and then you just you plant it
Yeah,
the one that you choose. So in a way, you also prevent
the gene from
Yeah.
from disseminating
Yeah.
of the gene from being passed on. Yeah.
Yeah, the very good example is our the famous actress Angelina Jolie.
Yeah.
And we all wonder if her mother were to do this,
Yeah,